reason, in general, eyes, like any other part of the body, are also no exempt from these injuries, in spite of the fact that they are well protected by lids, margin of the orbit, the nose, and presence of the orbital fat behind the eyeball. Ocular injuries may be grouped as follow: mechanical traumas, electrical traumas, chemical traumas, thermal traumas, and radiational injuries. They may be agricultural, may be industrial, and maybe domestic. And due to the specific properties, clinical features, we can divide all the traumas into the injuries of children and of adults. Let's start with the superficial injuries. It is usually extraocular foreign bodies. These are quite common in industrial and agricultural workers. A foreign body may be impacted in the conjunctiva or cornea. On the conjunctiva, it may be lodged in such an anatomical structure as sulcus subtarsalis, which is situated on the inner surface of both of the upper eyelid, a distance about 2 millimeters from the margin of the eyelid. Then we can find rather often such foreign bodies in the conjunctival fornices. Conjunctival fornix means place of junction of two portions, two parts of conjunctiva of the eyeball and conjunctiva of the inner surface of the eyelid. And on the surface of the conjunctiva of the eyeball, we can rather often find superficial foreign bodies. If you look at the lower picture, you see near the limbus, on the surface of the conjunctiva of the left eye, of the right eye, you can see the superficial foreign body. In the cornea, it is usually embedded in the epithelium or superficial stroma, rarely into the deep stroma, because cornea is rather solid structure with rather good protective properties. In the upper superior photo, you can see the intraocular superficial foreign body in cornea, in superficial layers of cornea. The usual foreign bodies are particles of iron, emery, and coal. In agricultural workers, these are parts of dust, sand, wings of insects. It may be dust, it may be glass, it may be steel. It's very important to know the properties of the foreign body. It may help us to remove it. For example, in some case of metal foreign bodies, we can use magnets to remove them. In case of non-magnetic foreign bodies, it's necessary to remove them by the forceps or other special needles or other specific instruments. In case of chemical foreign bodies, sometimes we can just wash the foreign body with the help of water or special antiseptic solutions. But also it's necessary to be very careful because sometimes several types of chemical substances in contact with the water, they can increase the degree of chemical burn. So in all the case, before you start to remove the foreign body, try to understand what do you see, what kind of foreign body do you see, and then think what is the best way to remove it. Foreign bodies produce immediate discomfort, profuse watering, like a protective reaction of the eye, and redness in the eye. Pain and photophobia are more marked in corneal foreign bodies than the conjunctival. Defective vision occurs when foreign body is situated in the center of the cornea. For example, we can suggest that in the superior picture, when the foreign body is in paracentral area of the cornea, it may be decreased visual acuity. Examination reveals marked blepharospasm, spasm of the eyelids, and conjunctival congestion. Congestion means dilation of the blood vessels of the conjunctiva, usually in the peripheral part, if we are talking about the conjunctival congestion. A foreign body can be localized on the conjunctiva and cornea by oblique illumination or slit lamp illumination. You know what this means. A lamp is special equipment, it's binocular microscope, and with a source of light in form of slit. So the name of this method of examination, when you see the enlarged eyeball through the binocular microscope, the name of this method is slit lamp examination. Complications of superficial foreign bodies are acute bacterial conjunctivitis. Of course, foreign bodies are non-sterile, so aggressive infection is one of the possible complications of the presence of foreign body in the conjunctival cavity on the surface of cornea and so on. A corneal foreign body may be complicated even by ulceration, and if it will be a purulent ulceration, it may be a purulent corneal ulcer, very severe disorder with a risk of perforation and other more severe complications. Pigmentation and or opacity may be left behind by the iron or emery particles embedded in the cornea. How to treat such patients with foreign bodies? Extraocular foreign bodies means not intraocular but on the surface of the eyeball should be removed as early as possible, as soon as possible, with the help of a wet cotton swab stick or special hypodermic needle after or under topical anesthesia. If possible, we try to use not very acute types of instruments, sometimes even cotton wool. If it's a very good fixation of foreign body, good connection with the tissues of the anterior segment of the eye, superficial structures, cornea and conjunctiva, we can use special needles. Don't forget to prescribe your patient antibiotics after removal of foreign bodies. Antibiotics in form of drops and ointments for about 3-5 days. We use them to prevent secondary inflammation, to prevent infection complications. Prophylaxis. It's necessary to use special protective glasses for all the workers, industrial, agricultural workers. We should prescribe them special protective glasses. It's really necessary. It's really can help to prevent such uncomfortable situations in most of cases. The next type of superficial traumas are corneal abrasion or corneal erosion. Corneal erosion is often the result of small foreign bodies, concretions, and trivial trauma, for example, in contact lens users or otherwise. These are very painful and diagnosed by fluorescein staining. We use special indicator in form of water solution, the so-called fluorescein. We instill 1 or 2 drops of this indicator into the conjunctival sac. Normally this indicator before the installation, it's orange in color. And then we wash it with any saline solution or just artificial tears or just water. And then we check the patient's eye with the help of the slit lamp examination. In areas of damaged cornea, in areas of presented erosion, after the contact with the erosion, the indicator changed its color from orange into the green, and you see the areas of damage, areas of erosion, the depth of erosion, rather easy. They look greenish during the examination. Very, very easy to determine the presence of this erosion, but sometimes rather difficult to treat it. The main symptoms of such a condition, like in case of corneal superficial foreign bodies: pain, photophobia, lacrimation like a protective reaction, treatment, antibiotic drops and ointments for about 3, 4, sometimes up to 7 days. Frequency of instillation depends on the area of the erosion, from 2, 3 to 5, 6 times per day. We have in our real clinical practice several drugs which can help us to increase the speed of recovery of the corneal erosions, and in case of large erosions, we can use them. They are usually in form of gels, usually they contain vitamin A, several other specific substances like hyaluron acid, and so on. But even without any special active drugs for recovering of cornea, we can see spontaneous epithelialization of the corneal erosion, even subtotal corneal erosion, in 3-4 days. So you can use, especially if it's very small erosion, you can use only 1 or 2 types of antiseptic solution or antibacterial drops, drops and ointment. You can combine them, but without any special drugs. And in 3-4 days, you'll see the epithelialization, total epithelialization, with the restoring of the normal surface of the cornea. The next rather large group of disorders are contusional injuries. These are caused by blunt trauma and may vary in severity from a simple corneal erosion to an extensive rupture of the globe. Let's discuss structure by structure all the possible changes of the anterior segment of the eye. So the orbit. What can happen with the orbital walls during the blunt trauma? There may occur fractures of the orbital walls. If you remember anatomy of the orbit, there are 4 main walls of the orbit: superior, inferior, lateral, and medial. Medial is the thinnest one, so rather often we can see the fractures of the inner wall of the orbital cavity. We can see the traumas of the inferior wall. Be very attentive when you are talking, when you have a patient with fractures of the superior wall of the orbit, because in its posterior third, the superior wall of the orbit at the same moment is the inferior wall of the cranial cavity. And if there exists a fracture of the bones with a dislocation of the fractured bones, we can think not only about the orbital trauma, but about the cranial trauma, open cranial trauma. And in this case, it's a real question: who should treat such patients, ophthalmologist or neurosurgeon? Because the risk of severe complications, vital complications, is rather high in this case. Common has been the blowout fracture of the orbital floor. Orbital hemorrhage may produce sudden proptosis, change of the position of the eyeball anteriorly. Sometimes maybe anophthalmos, when it looks like one eye is smaller than other one, but they are normal in the size, anterior-posterior diameter, but due to the position, abnormal position of the eyeball, which was after the trauma, we can see it looks like in this picture, in this photo, both eyes are normal. I mean, no changes of the eyeballs, but it looks like the right eye, here you see, is normal, but left eye, position of the left eye is, it looks like it's smaller than that one, but it's due to its change of its position because of the fractures of the floor of the orbit. Here you see the mechanism, fracture of the bones and the dislocation of the eyeball posteriorly and inferiorly. Orbital emphysema may occur following ethmoidal sinus rupture, and we can see, and during even X-ray examination, we can find bubbles of air in the orbital cavity. The next structure for discussion are the lids. And here you see the patient with the so-called ecchymosis of the eyelids. It's rather, ecchymosis is of frequent occurrence. It means, this term means subconjunctival hemorrhage. Because of loose subcutaneous tissue, blood collects easily into the lids and produce the symptom of black eye. There may occur ulceration and even avulsion of the eyelids. Traumatic ptosis, impossibility to open the palpebral fissure due to the paralysis of the palpebral superior levator muscle and impossibility to pull up the upper eyelid, may follow in case of several specific types of conjunctival of contusional traumas. Several words about the syndrome of black eyes. If it's unilateral, it's usually associated only with the traumas of this eye, of the structures which surround the eye, I mean eyelids, maybe bones of the orbital wall, and so on. But if you see, like in this picture, the bilateral black eye symptom, it looks like a black glasses syndrome. You should pay special attention to the general functions of the patient, because sometimes it may be the first symptom of the cranial basis fractures. And in this case, of course, not ophthalmologists, but neurosurgeons should treat such patients. Lacrimal apparatus. Lacrimal apparatus, as you know, include lacrimal gland, main lacrimal gland, which is situated in the superior and lateral part of the orbit, and lacrimal passages through which the tear outflow from the conjunctival sac into the nasal cavity. So we can see in our everyday life traumas of the lacrimal passages and lacrimal apparatus at different levels. It may be, if we're talking about the lacrimal gland, main lacrimal gland, it may be dislocation of the gland. It may be hemorrhages in structure of the lacrimal gland. It may be damage of the lacrimal gland by fractured bones of the orbital walls. In case of lacrimal passages, traumas, we can see sometimes rupture of the lacrimal canaliculi, damage of the lacrimal sac, damage of the, sometimes with the obstruction, damage of the nasolacrimal duct. Symptoms of these disorders are different in case of traumas of the main lacrimal gland. It may be, on the other hand, maybe lacrimation, severe tearing. On the other hand, maybe dry eye syndrome if it will be dysfunction of the lacrimal gland due to its trauma. If there exists a trauma of the lacrimal passages, it will be tearing, will be one of the main symptoms because of the impossibility of the tears to outflow through the normal lacrimal passages. And treatment depends on the etiology and type of the trauma and the clinical picture. Usually we use a sort of plastic surgery for recovering of the normal lacrimal passages or the normal position of the lacrimal gland. Conjunctiva. Subconjunctival hemorrhages are the most frequent types of conjunctival traumas. And here you see the patient with the severe subconjunctival hemorrhage. We can't see white sclera through this hemorrhage. It appears as a bright spot, maybe partial or maybe total, like here. Don't forget that such a clinical picture of a total lacrimal or subconjunctival hemorrhage may simulate the more severe trauma, like ruptures of the eyeball. And if you see such a picture, don't forget that under this blood may be very, very severe changes of the sclera, of the inner structures, loss of the contents of the eyeball. So before you start treatment of the subconjunctival hemorrhage, you should exclude more severe damage. Then corneal traumas, we have already discussed the corneal erosion and its clinical picture. Then the next one is scleral tears. It's the most severe trauma associated, it may be associated with prolapse of uveal tissue, loss of intraocular contents, loss of vitreous, intraocular hemorrhages, and dislocation of the crystalline lens. And repair should be done as soon as possible, sometimes even under the general anesthesia. Usually, in most of cases, we do not use in our practice in ophthalmology, in ophthalmosurgery, we do not use general anesthesia. We use local anesthesia in form of drops, injections around the eyeball, but in such a severe trauma, sometimes it's necessary even general anesthesia. So that's all about the contusions which cause the damage of the superficial structures. What about the inner structures or spaces inside the eyeball during the trauma? Let's have a look at the anterior chamber. Anterior chamber, it's a space between the posterior surface of the cornea and anterior surface of the iris. The depth of anterior chamber in its central part is about 3.5 millimeters in average, 3.5 millimeters. And the volume of the anterior chamber is 0.3 milliliters. Normally, anterior chamber is filled with the transparent aqueous humor. But in case of trauma, we can see blood in the anterior chamber, the so-called hyphema. We use a lot of Greek words, as you know, so this is one of the Greek words. Hyphema means blood in the anterior chamber. It may be like in this picture, rather small, in form of a level of the blood in the bottom of the anterior chamber, or maybe it may localized in the lower third or lower half of the anterior chamber. And sometimes in case of severe hemorrhages, we can see the total hyphema when the blood fills all the anterior chamber. In uncomplicated cases with a small hyphema, like in this picture, we can use only medical treatment without any surgery. But if all the cornea is filled with the blood, it's necessary to wash anterior chamber and through the paracentesis and to remove the blood, because the risk of development of complications like increased intraocular pressure and so on, toxic effects of presence of blood in the anterior chamber and so on. Uveal tract, which include, as you know, iris, ciliary body, and choroid. Now, let's start with the anterior part of the uveal tract, iris and ciliary body. And pupil. Pupil, you know, it's just a hole in the center of the iris, which can change its size by constriction and dilation. What can we see during the examination? We can see traumatic changes of the diameter, of the size of the pupil. It may be, on the other hand, maybe traumatic miosis, when we can see constriction of the pupil, or traumatic mydriasis, when the pupil is wide and can't be constricted due to paralysis of the sphincter of the pupil. It may be a rupture of the pupillary margin. And as in this picture, we can see iridodialysis, detachment of the iris from its normal place of fixation. It looks like additional pupils somewhere on the periphery of the iris. So very severe complication, which will be associated with decreased visual functions, but more severe complication is secondary glaucoma, post-traumatic glaucoma, due to such changes. Treatment of traumatic iridodialysis or pupillary margin ruptures is usually surgical. Crystalline lens. What can we say about the lens lesions? It may be contusional cataract, opacity of the crystalline lens due to trauma, of course, with the loss of visual functions. Treatment of cataract based on the general principles of cataract surgery, removing of the opaque lens and implantation of the artificial lens. Subluxation of the lens and dislocation of the lens posteriorly into the vitreous body or anteriorly into the anterior chamber. And here you see such a patient with the dislocation of the crystal lens. We can see only the superior pole of the lens, it's a symptom of the rising sun. And here we see that lens is partially opaque, dislocated posteriorly and inferiorly into the vitreous cavity. Of course, visual functions will be rather poor. In such an eye, we can have an increased risk of glaucoma development. Treatment only surgical. We should use vitreoretinal surgery to remove the opaque lens and to implant special artificial lens. Of course, this surgery is more difficult than the simple cataract surgery. And vitreous body. Vitreous, you know, it's a gel in the posterior part of the eyeball, which fills the posterior part of the eyeball, and vitreous hemorrhage, the so-called hemophthalmos. It's a total or partial detachment of the vitreous with bleeding into the vitreous cavity. Treatment also depends on the etiology and severity of these changes. In some cases, we have a possibility to resorb this blood in the vitreous body only with the medical drugs, but in case of severe changes, only vitreoretinal surgery with the removing of the vitreous body can help us to increase the visual functions of our patient. And now the posterior pole of the eyeball. What changes can we see in different structures of the eyeball? Don't forget that I named different structures and their changes, but it doesn't mean that at the same moment in one patient we can find all these changes. Of course, in some patients we can see only damage of only one of these structures. In some patients we can see combination of changes of different structures, but it's very seldom when we can see most of these symptoms and damage of different structures. So about the posterior pole of the eyeball, as you know, there exists part of the uveal tract, the so-called choroid, and it is in very close contact with the retina, neurosensory part of the of our eyeball, the inner layer in the coat of the eyeball, which is responsible for the visual sense and formation of the images. So traumatic changes of these structures is in most of cases are associated with severe loss of visual functions. So choroidal and retinal damages include choroidal and retinal hemorrhages. So here in this picture, you can see a lot of blood in the posterior pole. This is the orange and pinkish. It's a normal color of the retina, normal parts of the retina. And these red areas, it's hemorrhages, subretinal usually. Here you can see in the yellow spot the preretinal hemorrhages. So combination of different complicated hemorrhages in different parts of the fundus of the eye. Sometimes we can see rupture of the choroid, very severe disorder with a rather poor prognosis for the visual functions. And retinal detachment, detachment of the retina from its place of junctions with the underlying structures, with the development of the severe complications and loss of visual functions. Optic nerve. In this picture, you see the optic nerve. Damage of the optic nerve injuries are commonly associated with fractures of the base of the skull. This may be in the form of traumatic papillitis, traumatic inflammation of the optic nerve, usually non-infection, of course, but with other symptoms of the inflammation. Laceration of the optic nerve, then optic nerve sheath hemorrhages, and the most severe complication, avulsion of the optic nerve from back of the eye. It means detachment of the optic nerve from the eyeball. Of course, at the moment of detachment, the eye become blindness, and of course it's irreversible situation. We can't help such a patient. The only I think we can do, we try to save the eye as an organ, but in most of cases we can see after such severe trauma, we can see shrinking of the eyeball, loss of its function, loss of its form, and sometimes due to the risk of inflammatory complications, it's necessary to remove this eyeball and use artificial eye, no, I mean like a cosmetic procedure. Traumatic glaucoma, or on the other hand, traumatic hypothony may be the result of ocular injuries. Traumatic glaucoma is associated with the increased intraocular pressure and should be treated due to the according to the rules of glaucoma treatment. In case of hypothony, when the intraocular pressure decreased, there exists a risk of atrophy of the eyeball, shrinking of the eyeball, and by the medicine, so by the surgery, in some cases we try to increase intraocular pressure to prevent such complications. In this case, we think only about the saving of the eyeball as an organ, but not about the recovery of the visual functions due to severity of damage. But cosmetic purposes and the aim to save the eye as an organ is also good aim and necessary aim, and we try to do all our best to keep the eye its normal position, normal form, normal view. And now let's start the subtopic perforating injuries. They may cause severe damage to the eye and so should be treated as serious emergencies. They may be caused by sharp and pointed instruments, foreign bodies, traveling at extremely high speed. I mean, if the foreign body has enough energy to pass through the outer coat of the eyeball, it may come inside the eyeball and cause very severe damage. The main effects of perforating injury are mechanical trauma, which include wounds of the conjunctiva, cornea, uncomplicated or complicated, which are associated with prolapse of iris or other structures. For example, here in this picture, you see prolapse iris through the wound out of the eyeball. It's a very, very severe complication. Sometimes lens matter and even vitreous loss through the same wound. Damage of sclera and lens. Of course, such a trauma, open wound, is a window for the introduction of infection. Post-traumatic keratoconus, inflammation of the uveal tract after the trauma, anterior inflammation, and inflammation of the anterior part of the uveal tract, and sympathetic ophthalmitis, very severe complication, very seldom, but especially now when we use widely corticosteroids in case of traumas, but very, very severe due to the risk of the total and irreversible blindness. A bit later, we'll discuss more thoroughly the sympathetic ophthalmitis. How to put the correct diagnosis in case of perforative injury? One of the main aim to determine is it a real perforation or not. There exist reliable and doubtful signs of perforation. In case of reliable signs, we can see visible wound. If there exists a wound, open wound, of course it's clear it's a perforation. Prolapse of inner structures. If you can see even through the small wound the prolapse, of course it's a perforative injury. Sometimes we examine the eyeball but can't see any perforation, any wounds, but we can see aperture in the iris. Of course, it's the result of the previous perforation. The superficial layers may close the wound due to the connection of the different tissues, but if we can see the perforation, we can suppose that maybe it's even a foreign body inside the eyeball, which we have to remove. And of course, presence of foreign body. Sometimes you can see it with special equipment like slit lamp. Sometimes we can find it on the X-ray examination or ultrasound examination. Eye looks normal, but we can see inside the eyeball the part of the metal. Doubtful signs of perforative injuries. Hypothony. When we can see decrease of intraocular pressure of such patients. Of course, hypothony may be as a result of other types of traumas. Just several minutes ago, we discussed the hypothony as a symptom of contusional injury, dull trauma, but not perforation. But if you see hypothony, you can suggest that this is the result of the loss of the contents of the inner contents of the eyeball through the wound. And in this case, it's necessary to try to find any changes which may prove your suggestion. or to exclude the diagnosis of perforation and continue to treat such patient according to the rules of treatment of contusional injuries. Shallowing or flattering of the anterior chamber. If we can see if there exists a perforation in the anterior chamber, it means that the changes of the depth of the anterior chamber may be associated with this presence of this wound. And changes of the pupil shape. If there exists any perforation somewhere on the periphery, the pupil can change its shape from normal round into the oval, and it's also maybe a symptom of the perforation, but not reliable. So it may be as a result of other disorders. And about the immediate management of global perforation. Of course, antibiotics. The very often question how to use them. I mean, in what forms, systemically or topically. Systemically, in all the case of perforation, topical antibiotics, it's possible to use them in form of drops, and of course impossible to use in form of ointments because they exist a open wound. And you should be also careful with the local antibiotic because some of them have indication only for superficial use, and in presence of the open wound, if a lot of antibiotics come into through this wound into the inner parts of the eyeball, it may cause toxic effect, so you should be careful. So the best way is to use it systemically. And then tetanus antitoxin should be administered, in case of all the traumas, and it's not an exclusion, eye trauma. So tetanus antitoxin should be administered. We have already discussed antibacterial drops. Yes, it's possible in most of cases, but some in case of large wound, you should think before use them, and don't use antibacterial ointments. And binocular bandage. Binocular bandage is used to decrease the movements of the eyeball. Even if you have a trauma of one eye, if you put bandage only on injured eye, you understand that with a healthy eye, it will be all the time will be movements, and under the bandage, of course, will be the same symmetrical movements of the injured eye. And in case of perforative trauma, it's necessary, it's rather important to exclude any movements. So to decrease the amount of these movements, we can put bandages on both eyes to exclude them. Ultimate therapy is surgical repair under local or general anesthesia. A wound should always be sutured. It's the only way to save the eye as an organ. It's the only way to prevent secondary inflammation. It's the only way to prevent severe complications. And after the small break, about 10 minutes, we'll continue with the intraocular foreign bodies, their types, their localization, the diagnostic tests for intraocular foreign bodies, and we'll try to think together how to remove them to save the eye and to increase the visual functions. So let's have a small break, about 10 minutes, and then we'll continue with the foreign bodies.
Okay, sir.